Next we come up to Chapter 16 for Sensory, Motor, and Integrative Systems. A lot of things we're going to be talking about here are things I use in practice quite often, in particular trying to influence the sensory and integrated systems to achieve better motor output. In this case, a lot of times trying to at least calm down muscles or trying to improve any kind of pain response, but you will see, or at least I'll try and explain, some of the things I normally use in practice that utilize these particular techniques. So let's define terms here first. So we look at sensation is both a conscious and subconscious awareness of changes in both the external and internal environment, whereas perception is only the conscious interpretation of sensations performed mainly by the cerebral cortex. Now each type of sensation we have is known as a sensory modality, and it's going to be a lot more than we used to learn back as we were kids. There's a lot more than 5 different sensations, but they do include smell, touch, pain, vision, hearing, and they're going to be grouped in either general or special senses. The general senses are going to include the somatic, which include tactile, both gross and motor, thermal, and proprioceptive. Proprioceptive we'll get into a little more. That's the nickname more position sense, which I'll get to a little bit when we get to joints. In addition to the other somatic senses, you'll find the visceral. This includes different types of pressures, blood pressure, chemical balances, stretch reflexes, which we talked about before, in both the muscles and the tendons, feeling of nausea, hunger, and also temperature. We're also grouped into special senses. These are ones that most of us are familiar with back when we were kids, which include the smell, taste, vision, hearing, and equilibrium, or touch, as some people like to call it there, although touch is a very, very, very broad category here. So different types of sensory receptors we'll find are going to be involved with different senses, which we'll get into more in the last chapter, special senses. This one here shows a free nerve ending. This should look somewhat familiar to you back when we did the integumentary system. So this one will detect pain, cold, heat, and also itch sensations. And these are a couple other ones that we also use as well. They'll include temperature and also some deep touch or fine touch. So again, the free nerve ending is shown there in letter A. Will include cold stimulus or heat stimulus. You look at the encapsulated nerve ending in letter B. This is more for vibration sense. This is the Babinski corpuscle. Or you have another specialized neuron here called the sensory receptor. This is more so for gustatory or taste receptors you see in letter C. So here we see a better shot of the encapsulated nerve endings that we find with the Babinski corpuscles that are good for pressure, vibration, and some forms of touch. And here's your special gustatory receptor cells. You also find other types of special sensory cells when you look at the photoreceptors in the retina of the eye, and the special hair cells found in the inner ear for hearing, also for equilibrium as well. Here's a quick overview that is actually the same slide we used back with the cranial nerves as well as the spinal cord and the spinal nerves as well. It does have a separate section for the special senses as well. Now, some of the receptors can be grouped based on where we find the receptors and what kind of stimuli are going to activate them. So in this case, exteroreceptors are going to basically detect the outside environment. So as you would assume, you find the majority of these, if not all of these, in the integumentary system, which include the hearing, vision, smell, taste, touch, pressure, vibration, and pain. You can also include itch there as well. Next, we have interoreceptors, which are going to monitor the body's internal environment. So this will also include any kind of receptors that we have in the gastrointestinal tract, genitourinary tract, respiratory tract, as well as cardiovascular system as well. In addition, all the proprioceptors. These are very important for helping with information regarding body position, muscle length, and position of joints. So in other words, this is one of those things that any of you have ever done the drunk test before, with your hands outstretched, eyes closed, head back, you're still able to touch your finger to your nose as long as you're not inebriated because of what we call proprioceptors. So even though your eyes are closed, you still have an idea where your body is positioned in space, be able to maintain posture and be able to touch the nose without much difficulty. Here's a nice little chart that gives you an idea based on the classification of different types of receptors, which include the microscopic structure. And we'll get into some of those a little more so when we get into special senses. Also look at where they're located at and what kind of stimulation that they're going to detect. And then types of stimulus detected as well, which I didn't go over too much, but it's pretty much self-explanatory. Your mechanoreceptors are going to detect mechanical impulses. This could be touch, temperature, vibration. Thermoreceptors, obviously for temperature. Nociceptors, which we didn't talk about too much, these are your pain stimulators. your free nerve endings. This can be sharp pain, this can be dull pain, throbbing pain, and we'll look at how the nociceptors actually are very important for how your body reacts to certain types of stimuli and what happens to the motor function in particular, and how we as practitioners, especially in the physical realm, can help manifest better responses to the nociceptors. Photoreceptors found in the eye, detecting light. Chemoreceptors can be found for taste, smell, and internal bodily fluids, so it checks for electrolyte balances, checks for blood pressure, oxygen, carbon dioxide. Osmoreceptors are mainly for the osmotic pressure of fluids. So your somatic senses, again, the body sensations are going to include your tactile senses, thermal, pain, and proprioceptive. But you have different types of subsets for tactile sensations, which will include touch, both deep and superficial, pressure, vibration, itch, and tickle. It's important to remember that itch, tickle, and pain are actually 3 different types of receptors. Now, some of this should look familiar to you. This is a cross-section of the integumentary system, 3 layers of the skin. So we're going to look at the epidermis, the dermis, and the subcutaneous layer. For the most part, all of your nerve endings will be found in the dermis. Some of the free nerve endings will extend to the bottom layer of the epidermis here. So you can see your free nerve endings will detect pain, itch, tickle, cold, and warmth. You have different types of touch sensations. We'll look at both type 1 and type 2. Cutaneous mechanoreceptors, if you remember the tactile discs, these are for fine touch and pressure. If you jump down to type 2, these are your Ruffini corpuscles. These are more for crude touch and stretching of the skin. These are what's known as slow adapting type of neurons. So very simple, what happens is a slow adapting neuron, as long as there's some kind of stimulus there, they'll keep on firing. So these are going to be, if you have any kind of pressure onto the fingers, as long as pressure is still there, you'll still detect that particular sensation. Now the difference is you can have a rapidly adapting type of neuron. We're going to look at both the corpuscle of touch, otherwise known as the Meissner corpuscle, and also the laminated or Pacini corpuscle here. Now the difference being the Meissner corpuscle also will sense fine touch, pressure, and slow vibration, but unless the stimulation changes, in other words, if the stimulation stays the same, the neuron actually will adapt to that stimulation, very similar to if you put on your shirt in the morning and then after a few minutes you don't necessarily detect the shirt on your skin anymore. That's an example of a very rapid adapting type of neuron. So unless you shift a bit, or let's say if your shirt gets wet, then it's a new stimulus, and now all of a sudden you'll detect that again through the corpuscle of touch. So the same thing goes for the laminated or the Pacini corpuscle, except these will detect deep pressure as well as fast vibration. So those of you who have had any kind of massage done or have any kind of massagers, like from a chair, you kind of feel the sensation very quickly at first, then you kind of get quote-unquote used to it. These laminated corpuscles are basically fast adapting to that sensation. Now, if you were to increase either the frequency or the depth or strength of the vibration, then obviously you would detect that again, and it would take a few seconds for that to reacclimate to that particular type of vibration. And of course, the last one we'll show here is going to be the hair reflexes. This also helps detect crude touch. That is going to be a slow adapter. Next, we'll look at Thurman receptors. These are going to be fast adapting at first, although if there's a sustained contact, these tend to be more of slow adapters. So very soon we start getting into the painful aspects of the temperature changes. So the cold receptors are going to be found in the epidermis and the stratum basale. The warmth receptors are going to be found a little deeper. They're going to be less abundant, found mostly in the dermis. Now also your pain fibers will fire off outside of the centigrade range, either less than 10 degrees Celsius or centigrade, or greater than 45 degrees Celsius or centigrade. Your somatic senses are going to be 2 types. Particularly we're talking about pain. You have fast and slow. So the fast pain is pretty easy to remember because it's mostly acute, sharp, or prickling, where it's going to proceed within less than about a 1/10 of a second. The slow pain, these are going to get the burning, the aching, the throbbing. This is mostly where the chronic pain comes into play, which I see a lot in my practice. This can be perceived roughly in about a second or more. It can be a longer lasting type of stimulus. You can have superficial somatic pain, which arises from the skin receptors. And we look at deep somatic pain, which actually has some very different pain patterns along the skin. Some of these you'll look at from different organs. Like one of the things we always talk about, the heart. If you have any kind of heart discomfort, a lot of times it can project down the left side of the chest and down the left arm. And we'll look at different pain patterns there as well. Also, certain muscles, if you ever heard of trigger points, certain muscles, when they get knotted up, can transmit pain away from the muscle itself in very distinct patterns. So deep somatic pain is coming from the skeletal muscles, the joints, the tendons, and sometimes the fascia as well. Sometimes, again, like I mentioned before, you can get deep visceral pain, and these are usually going to be overlapping patches of skin that are going to be very indicative of whether there's a problem with a certain particular organ. These are known as referred pain. They follow very distinct patterns, and we kind of differentiate these, especially in my office, because I've had numerous people come in, think they were having some kind of heart attack, and we found out later it was just simply a muscle. Simply knowing these pain patterns, especially if you get into healthcare, can be very beneficial to either detect something that could be either life-threatening or something that can very simply ease the patient a bit and let them know that's not something that's really that problematic. But of course, you want to correlate that with different types of findings, both clinically and also through diagnostic testing if possible. So look at different somatic sensations and pay attention to this slide. You will probably see this again, most likely on the final, although we'll probably look at the more prominent ones. One in particular is going to be the heart. So most people, if they have any kind of heart pain or have any kind of heart attack, you can notice it's going to be sharp pain or long-lasting achy pain across the left side of the chest and down the left arm. It doesn't always have to be down the medial part of the arm. It can go down the anterior and also lateral, depending on the person. Liver and gallbladder predominantly is going to be in the right anterior and also the right posterior of the thorax. The stomach oftentimes will be just inferior to the xiphoid process, but also mid-thoracic pain there as well. People that have stomach indigestion or have a lot of gas can also have a lot of pain in the middle part of the thoracic spine. The last one I'm pointing out that can be very beneficial is the kidneys. So a lot of times with kidney pain, and those of you, unfortunately, if you've ever had any kind of kidney stone, a lot of times you have very deep referring pain around the anterior and posterior portion of the abdomen, and a lot of times it can also transmit into the pelvic region or also into the genital regions as well. So proprioception. So we look at proprioception as just simply the recognition of position of body parts, whether it be muscles, joints, tendons. The proprioceptors themselves are the actual nerve endings that we found in muscles, joints, and tendons. So we see three different types of proprioceptors, two of which should be very familiar to because we looked over those back in the spinal cord chapter and the spinal reflexes. The muscle spindles, you'll find those deep in the belly of the muscles. They've evolved with these stretch reflexes, which monitor the length of the muscles themselves. You'll find tendon organs, obviously found in the tendons, help protect the muscles and tendons from any kind of damage from overstretching. The new one is going to be the joint kinesthetic receptors. These can be found only in synovial joints. So as far as the TMJ, you find it in the fingers, in the shoulders, knees, hips. Anything with a synovial joint will have a joint kinesthetic receptor. These respond to pressure, acceleration, and deceleration during motion. They also will contain receptors to protect against any kind of excessive types of strain. So these are very important, especially for any kind of fine motor type of movements. Something simple as walking, to be able to detect how your foot actually touches the ground and how the knee and the hip will follow, or somebody just taking a pen and writing something down, or even when you're typing with a keyboard. All of these are based upon the joint kinesthetic receptors. So here we see a shot of both the muscle spindle as well as the tendon organ. Notice with the muscle spindle, it's going to have the neurons wrapped around the intrafusal muscle fibers. You see the extrafusal muscle fibers just outside of that particular capsule. Go a little further distal into the tendon, you can see the tendon organ capsule embedded deep within the connective tissue of the tendon itself. Here's a nice little table that breaks down what type of receptors that are grouped together. You're looking at different types of tactile receptors and give you an idea of where they're located and what kind of structure they're embedded therein, as well as sensations and also the adaptation rate. Now I made a mistake when I talked to you about the reflexes. These are going to be rapid adapters as well as the corpuscles of touch and also the laminated corpuscles. So again, these are all rapidly adapting. So as long as stimulation, if it does not change, then the receptor will stop firing off unless a new stimulus is detected. In comparison to the type 1 and type 2 mechanoreceptors, these are slow adapting. So once the stimulus is still there, it will keep firing off until the stimulus is removed. Now both itch and tickle receptors, this can be both slow and rapid. As far as Thurman receptors go, both warm and cold receptors, initially they're rapid and then they're going to be slow, especially if you're in the outside range of either less than 10 degrees Celsius or greater than 45 degrees Celsius. Your pain receptors, almost all of them are slow adapters, although they can detect both sharp or acute pain versus the chronic or deep burning pain. And of course, we have the proprioceptors that we talked about before too. Your muscle spindles and tendon organs tend to be slow adapters, but the joint kinesthetic receptors tend to be relatively rapid. So with that being said, if you're actively moving a joint, you're actively putting in new stimulus, so they're constantly firing off the receptors. Whereas if you're static, a lot of times they will actually condition themselves and actually will not be firing off unless you add a new position or unless you have any kind of fast acceleration or fast deceleration. So we talked about the different types of receptors. Let's talk about how the brain actually integrates those particular receptors. So the first thing to look at is the somatic sensory pathways. So these can go from the receptors to the primary somatosensory area, to postcentral gyrus, which is going to be found in the parietal lobes and the cerebral cortex, and also sent to the cerebellum. As you remember, the cerebellum is the major coordination center for motion. So basically it's going to consist of 3 different types of neurons that will affect the pathways. You have first, second, and third order neurons. Let's take a look at where they all synapse. So these go in sequential order. All of our first order neurons are going to carry the impulses from the somatic receptors from the brainstem or the spinal cord. So these may come out from the periphery through all the different spinal nerves, or may come from different cranial nerves. So they come from the eyes, the joints, the ears, the muscles, the tendons, so on and so forth. They will synapse at the brainstem or spinal cord, depending on where they're coming from, at the second order neurons, and they will always travel to the thalamus, with the exception of the small receptors, which we'll get to later on. And then from the thalamus, they will go to the different types of areas of the cortex on the same side. They'll go to the primary somatosensory area. They may actually also synapse with different types of areas like the primary gustatory area, the primary taste area, and so on and so forth. But the main thing to remember here, if you can keep in mind, the first order neurons first are going to carry impulses from the periphery to the brainstem or the spinal cord. And if you remember the thalamus being the next synaptic area, you can pretty much lay these neurons down in order: first, second, and third order. Just again, just remember where they're coming in from initially. They're going to synapse at the brainstem or the spinal cord, and then to the thalamus, and then finally to the primary somatosensory area of the cortex on the same side. So next we're going to look at the different sensory pathways, and remember these are going to be ascending tracts. First one we're going to look at is the posterior column or the medial lemniscus, which is going to take the impulses from the limbs, the trunk, the neck, and the posterior head. This is going to include the gracile fasciculus and also the cuneate fasciculus. Again, these can be found in the posterior column of the spinal cord. These are ascending pathways. See all 3 neurons of 3 orders transmitted from the right upper limb as well as the left lower limb. They're coming off the sensory trunk by the dorsal root ganglion. The first order neurons will synapse as they travel up both the gracile fasciculus and the cuneate fasciculus. It will synapse at the medulla. From there, the second order neurons will synapse further up to the thalamus, and finally synapse to the third order neurons to different areas of the somatosensory area of the cortex. So another sensory pathway, known as the enterolateral or spinal thalamic pathway, is integral to a lot of physicians in particular, especially those that deal with pain impulses. So this particular pathway deals with pain, temperature, itch, tickle, and also the posterior head as far as sensation goes. We look to try and interrupt this particular pathway, and I'll show you ways that can be done very commonly in healthcare nowadays. So let's take a look at the actual pathway itself. So from here you see the first order neurons coming in again to the sensory portion of the spinal nerve from the dorsal root ganglion or the posterior root ganglion as the first order neuron, and this will synapse right at the spinal cord level. So the second order neuron will actually start at the spinal cord level and transmit up the anterior spinal thalamic tract. It will cross over, in this case, from the right to the left. From there, it'll directly synapse as it bypasses the midbrain up to the thalamus, and again, will also synapse there for the third order neuron, which will go to the primary somatosensory area of the cortex. So as you can see, the right side of the body will receive the sensory input, synapse at the spinal cord level, which will be very important in a few minutes that we'll explain. And then as the second order neuron will transmit up the ascending spinal thalamic tract, it will synapse at the thalamus for the third order neuron, and then finally synapse in the somatosensory area of the cerebral cortex. And we'll see different parts of the cortex will correspond to different body parts. Finally, we look at the trigeminal thalamic pathway, which is very similar to the spinal thalamic pathway, except this is going to be drawn off the trigeminal nerve, cranial nerve number 5. And it's going to detect somatic sensations, both tactile, thermal, and pain in the face, the cavities of the nose and the mouth, as well as the teeth. So these will also go to the cerebellum as well, to the spinal cerebellar tracts. Now for the sensory pathway of the trigeminal thalamic tract, this is going to synapse a little bit differently than the past two we just looked at here. So it'll still draw sensory information through the ganglion here, as the first order neuron will transmit and synapse both the pons and also will descend in this aspect into the medulla with the second order neurons, and then will travel up towards the midbrain as it will synapse with the thalamus in the second order, and then finally to the third order neuron out to the primary somatosensory area of the cerebral cortex. But again, this one does cross over as well. So again, input from the right side of the body will end up on the left hemisphere of the somatosensory area of the cerebral cortex. Now, if you remember back in chapter 14, we talked about brain anatomy, and we had the central sulcus that basically partitioned the frontal lobe from the parietal lobe. Just behind the central sulcus in the parietal lobe was called the postcentral gyri. This is going to be the dedicated area for the primary somatosensory area. So basically what we're going to look at is different regions of the brain, especially in areas of the body that draw in a lot of sensory information. Are going to have a large patch of that particular part of the gyri dedicated to that body part. Conversely, if I have an area of the body that does not receive a lot of sensory input, we'll find a very small patch dedicated in the postcentral gyri. And we're going to see a very distorted map, also known as a homunculus, which is kind of, if you guys remember the old cartoons where the head of a character would be really huge and really small body, this is an example of a homunculus. So here we see the sensory homunculus found in the postcentral gyri. As you can see right off the bat, and you see the area of the face in particular, as we know obviously from the tactile sense, the lips take up a very major part of this part of the parietal lobe, followed by the face, the nose, and also you see the eyes there too. Now this is eyes from the sense of touch, tactile sense, not for sight. So very simply, someone putting in a pair of contacts or putting water drops in the eyes, we're feeling with the sensation of tactile sense, not necessarily for sight. We'll get into sight when we get into special senses. You also notice too, there's a very large portion dedicated to the hand and to the fingers, and yet a very small portion dedicated to the elbow and the arm and the forearm. You look further on down towards the center of the parietal lobe, you see that again the foot tends to have a little more dedicated area of the brain matter there versus the limbs themselves in the leg and also the lower leg. So the areas again where we have most of our sensory receptors will have a larger area of the postcentral gyri dedicated to that spot. And we've mapped this quite a bit from people that have had brain injuries, strokes, that kinds of things. So again, from a sensory aspect, it's dominated mostly by the hands, the feet, and also the face. In some portions, it could also be sensory information coming in from the gastrointestinal tract, as you can see, intra-abdominal areas as well. But again, most of the sensory homunculus is going to be dedicated to the outside environment. The final set of sensory pathways we'll talk about are the spinal cerebellar tracts. We're going to have a posterior and anterior tract. So these are going to carry the proprioceptive impulses. Now these are going to be the deep sensory information coming in from the joints, as well as part of the muscles and tendons. They'll send the impulses to the cerebellum, which remember before is going to be the major coordination center for movement and for posture. And tables here will give you a little cheat sheet of each of the different types of sensory tracts we had discussed earlier. So again, the posterior column will be comprised of the gracilis fasciculus as well as the cunei fasciculus. The spinal thalamic tract is mostly going to be for pain, cold, warmth, itch, and tickle. And you'll see a couple other ones in a couple seconds here. You'll find the trigeminal thalamic tracts will share aspects of both the posterior columns as well as the spinal thalamic tracts, except they're going to draw sensory information from the face, the oral cavity, as well as the nasal cavity. So touch, pressure, itch, temperature, as well as some pain aspects as well are going to be synapsed through the trigeminal thalamic tract. Again, through three order neurons. So first, second, and third, they'll synapse in different areas. Go back a few slides, look at the actual pathway. And finally, rounding out the sensory pathways are going to be the anterior and posterior spinal cerebellar tracts. As you can see with some of these, it tells you where the information is coming from, meaning the spine, and where it's going to synapse to, in this case the cerebellum. So again, this is more so for coordination and finely tuned movements, as well as maintaining certain postures and balance. Now the motor pathways are set up a little bit differently. So basically, instead of having three different orders of neurons, you're basically going to have lower and upper motor neurons. And these will come into play very simply when we talk about reflexes in particular. We're talking about the autonomic nervous system, but also for the somatic nervous system. You'll see both the lower motor neurons and the upper motor neurons will function differently. So basically the lower motor neurons are going to be the areas of the cranial nerves as well as the spinal nerves, which we discussed a couple chapters back. So again, this is going to be somatic nerves. These are going to be motor or descending tracts of information. But again, the lower motor neurons are going to be more towards the periphery. These will synapse at the spinal cord or at the brainstem in the case of spinal nerves and the cranial nerves respectively. So the somatic motor pathways are going to be made up of four different areas, four distinct circuits. You have local circuit neurons. These are basically going to be the lower motor neurons in the brainstem and spinal cord. These will form most of the nerves you're very familiar with, which include the cranial nerves like the trigeminal nerve, hypoglossal nerve, other nerves that we see also from the brachial plexus, like the median nerve, looking at the musculocutaneous nerve, and also the lower extremity looking at the sciatic nerve as well as the femoral nerve as well. You also have the upper motor neurons. These are going to come from the cerebral cortex or some of the cerebellum, and these will synapse with the lower motor neurons and lower circuit neurons as well. Finally, you have both the basal nuclei and the cerebellar neurons, so 3 and 4. These are going to assist motion and basically control the activity of the upper motor neurons as well. If you remember, the basal nuclei will give you the intention of motion. It'll monitor the motion as well. The cerebellar will actually get feedback from those areas to give more pinpoint or fine motor control based on the kind of movement that you're doing. We're trying to maintain certain postures. So we see here on the somatic motor pathways, this will be set up a little bit different than the sensory pathways. So first we look at the local or the lower motor neurons at number 1 here. So if you remember doing the stretch reflex as well as the tendon reflexes we had done a couple chapters back, these neurons here act upon a certain type of stimulus almost right away. At the same time as it's acting upon the stimulus, it's sending sense information back up to the brain and also the brain stem. So you can see in number 2, you have the upper motor neurons from the brain stem and also from the cerebral cortex, one on the left, one on the right here, acting almost simultaneously, affecting the particular reflexes happening at number 1. And while all this is happening, you got the basal nuclear neurons as well as the cerebellar neurons that are actively sending information back and forth and sending information down the descending tracts to allow both the upper and the motor neurons of the lower area to respond effectively. And again, without these, we see very uncoordinated motions. We see sometimes flaccid reflexes or hyperreflexive reflexes as well. You see problems with muscle tone. And this can be anything from the skeletal muscles in particular. We look at different pathways in motor pathways, especially the autonomic. Then we also have problems with the cardiac and the smooth muscle. So since you guys have done, or at least have seen some of the reflexes being done before, let's do 2 critical thinking questions. I'll have you answer towards the end of this chapter. First, what type of reflex response would you expect if there was damage to a lower motor neuron? And the inverse, what type of reflex response would you expect if there was damage to an upper motor neuron? So if you look back at that particular slide, one back, if you have any damage to the lower motor neuron, so these are going to be the spinal nerves going out to the anterior portion of the spinal nerve. So if you remember in particular, if there's an action potential traveling down the nerve, that will cause an action potential at the muscle, at the neuromuscular junction. If that is damaged, what would you expect to find with that particular muscle? Now on the flip side, the upper motor neurons, these often act as an inhibitory type of reflex onto the lower motor neurons. So if there is damage to the upper motor neuron, which you find in either the brain stem or found in the cerebral cortex, then we see a hyperreflexive response. So here are the answers to both of the questions first. So if we had damage to a lower motor neuron, we would see flaccid paralysis, which means that the muscle does not respond to stimulus, and it's very weak, almost jelly-like in paralysis, where it's weakly contracting, if at all. So it was known as hyperreflexia. basically see a very minimal, if anything at all, or sometimes no response to the reflex tests. And again, the muscle tone tends to be very, very weak. On the flip side, if you have an upper motor neuron damage, these will inhibit, or will actually allow the lower motor neurons to actually react too appropriately. So you get what's called spastic paralysis. In other words, it goes in spasm and it stays in spasm, otherwise known as hyperreflexia. When we do the stretch test or the tendon test, you'll see a lot of times, especially with the knee itself, you see a very aggressive response. The muscle tending very spastic, very rigid, sometimes very painful as well. We see this a lot in kids in particular, although it's not a problem in kids, known as Babinski Sign. Babinski Sign, very simply, is if you're using a reflex hammer, there's a blade-like portion on the bottom, not very sharp. In a kid, what should happen is if you draw the bottom of that reflex hammer across the bottom of the foot, the baby's toes will actually split apart or flay out in dorsiflexion. That's a normal response for a baby. Because very simply, the upper motor neurons have not synapsed appropriately yet for with the lower motor neurons down the spinal cord level in the lumbar spine. Now, if you do this to someone like you or I, or someone who's an adult, the appropriate sign is if you do the same reflex where you draw the reflex hammer across the bottom of the foot, the toe should curl in or go into plantar flexion. Now, when you see the opposite reaction, if I had an adult that came in, and let's say I did the Babinski test, and I stroked the bottom of the foot and the toes did not curl forward, and let's say they opened up in dorsiflexion, it's a clear indication there's a problem with the upper motor neurons, in this case usually in the cerebral cortex or cerebellum, which means that they're not inhibiting the lower motor neurons appropriately. Now, we looked at the sensory homunculus before at the postsensory gyri. Now let's look at the motor homunculus. So you'll see somewhat of the same distribution of different body parts here. You would naturally assume the hands would have a lot of area of the frontal lobe dedicated to fine motor control and also strength. Also, you'd see the same thing with the face in particular, but notice the lips and the mouth in particular, how it's very elongated, which means there's a lot of space attributed to those particular movements. But also in particular, you're looking at different types of motions as well. So it could be vocalization, which includes the vocal cords themselves, as well as formation of the mouth as well as the lips, salivation as well. And then also a little deeply, you see also mastication, which also has a very, very strong dedication or surface area for control of the jaw, the tongue, and also in swallowing. Naturally, you can see too, the feet have a pretty good representation through there. Not a whole lot is dedicated to the proximal limbs, so the upper arm as well as the thigh, although that doesn't mean it doesn't attribute a lot of strength to those areas. But there's not as much fine motor control in those particular spots of the trunk as well as the proximal limbs. So again, for more fine motor control, whether it be for hands, the feet, and the face as well, you're going to have a lot more surface area of the frontal lobe dedicated to those particular motions. So again, for the somatic motor pathways, these are descending tracts. So we're taking information from the cerebral cortex and sending information down towards, from the upper motor neurons to the lower motor neurons, down two distinct pathways. One is going to be voluntary, one is going to be involuntary. So very simply, direct motor pathways, these are voluntary. So these are going to be delivered from the cerebral cortex to the lower motor neurons, or the indirect motor pathways, these are going to be autonomic. They're going to send from the areas from the brainstem down to the lower motor neurons. So in particular, if you remember, chapter 2 back, we talked about the midbrain, the pons, and also the brain stem, the medulla oblongata, excuse me. So basically, these areas will control a lot of the autonomic functions of depth of breathing, heart rate, and so on and so forth. So as you can tell, there's a very quick, almost animalistic type of response, again, from the autonomic nervous system. Now, if you remember way back when we talked about the medulla oblongata, the pons, and also the midbrain, we talked about the pyramidal and also the extrapyramidal tracts. The pyramidal tracts will be your direct motor pathways, and we find two distinct direct motor pathways. One is going to be the cortical spinal pathways, which will be partitioned into the lateral and the anterior. The lateral cortical spinal tract will be for motions of the hands and feet, so it's going to be more the distal end of both sets of limbs. And also you have the anterior cortical spinal tract, that's more for the trunk and also the proximal portions of the limbs. So again, if you look at lateral cortical spinal, so remember it's a descending tract from the cortex to the spine. We see the same thing with the anterior cortical spinal tract there as well. Now, for the face and for the head, you have the corticobulbar pathway. These are cranial nerves 3 through 7, also, and down also through 9 through 12. So you might think for a quick second, why only cranial nerves 3 to 7, also 9 to 12? Because each one of these has, at least in some aspect, motor control to some muscle in the face or also in the head. So you can see here, movement originating from the right side of the cerebral cortex. The upper motor neuron will pass down through past the thalamus to the midbrain, the pons, and to the medulla. It's going to decussate or cross over at the pyramidal pathway to the left side of the body. In this case, to the lateral corticospinal tract. It's going to go down to the distal part of the limbs, down to the lower motor neuron, right at the spinal cord level, corresponding to whatever body part that we're talking about. Here we see almost the same thing except for the anterior corticospinal pathway. So again, it's going to originate from the precentral cortex of the precentral gyrus on the right side of the body. It'll go through the upper motor neuron. It'll descend down towards the pyramid. In this case, it'll stay at the same side, and then it'll actually desiccate at the spinal cord level, in this case, the proximal part of the limbs. And again, depending on what body part we're talking about, this could be either the upper arm or the brachium, it could be thigh, or it could be along the trunk if we're dealing with the intercostal muscles. So here we're looking at the corticobulbar pathway. If you notice on the lateral portion of the frontal lobe there, this is going to deal mostly with speech patterns or vocalization. So the upper motor neuron will originate at the very lateral portion of the frontal lobe. It'll travel down through the midbrain and it'll synapse at the facial nerve. It'll actually transmit both to the left and the right side here. So in this case, showing both the facial nerve as well as the hypoglossal nerve. This is more for the muscles of facial expression, also the muscles of the tongue. So this could be to forming different types of speech or doing different types of facial expressions. Now, as far as the extrapyramidal tracts, the indirect motor pathways, these are going to be involuntary. Remember way back when we talked about the red nucleus found in the medulla oblongata. The cerebrospinal tract will pass right through there. This aids in the lateral corticospinal tract with voluntary motions. So if you remember a couple slides back, we looked at both the upper and lower motor neurons. They act on their own, but also receive input from the cerebrospinal tract there as well. So again, this is the aid lateral corticospinal tract for voluntary motion. Next, you have the tectospinal tract, which is going to actually be both the superior and also the inferior colliculus. Whereas the superior colliculus is going to be the reflex to sight stimulation, whereas the inferior colliculus will be more for auditory stimulation. So if you think of it this way, if you see a flash of lightning, your eyes are quickly directed to that particular spot, so it orients your head so you can focus on that more quickly. Also, when you hear the thunder, or if you hear any kind of distant call, it orients your head, so again, your ears will be equidistant to the sound, so you can hear that sound again. So it's both the superior and inferior colliculus helps you orient your the head itself to any kind of visual stimulation or any kind of auditory stimulation, depending on which colliculus we're talking about here. This becomes very important when we look at one of the tests we're going to use in the Special Senses lab, which will be the last time I think you guys will wind up doing. So one of the tests we use with the ruler will involve using both the superior and also the inferior colliculus to use a particular type of command word. So this will be the answer to one of the questions I'll pose to you during that particular lab, so be mindful of that. One of the other things that we test as well is going to be the vestibulospinal indirect pathway. This one here basically takes information from the cerebellum and also will give input to the upper and lower motor neurons for the body to act upon it. So it helps regulate posture, and we get different stimulus from the eyes, whereas your eyes, for the most part, want to maintain some kind of level with horizon. The ear, the inner ear in particular, gives you an idea of how you orient yourself in space, and we'll talk about the mechanisms there. We'll talk about the actual ear anatomy. And finally, joint proprioceptors we had talked about before, where we talk about how our limbs in particular are going to be in space. So obviously, even with your eyes closed, you can still detect where your hands, your feet are in relation to everything else. And finally, we're going to look at both the lateral reticulospinal and the medial reticulospinal tracts. These will originate from the reticular formation. Again, send more information down through extrapyramidal tracts. These are mostly for balance and muscle tone. For the most part, I just want you to be aware of that the lateral reticulospinal will excite neurons. The medial reticulospinal will inhibit certain neurons, and this actually helps control very fine motor motion. So, quick recap: you've got the corticospinal tracts, both the lateral and the anterior. So basically, for the lateral corticospinal, will be mostly for precise voluntary motions of the distal part of the limb. So, we're looking at the hands and the feet in particular, and all the muscles that will function in those body parts. Whereas the anterior cortical spinal, these are mostly for the trunk as well as the proximal limbs, for both proximal portions of both the upper and lower limbs. Finally, the corticobulbar is going to be mostly for dealing with all the muscles of the face and also the head. And finally, looking at the indirect motor pathways here, the 4 tracts we want to be aware of are the rubrispinal, which passes through the red nucleus. This will aid or send input to the corticospinal tracts in particular. The tectospinal will take information from both the superior and also the inferior colliculus, so the body can respond to both visual and auditory stimulation. You have the cerebellospinal tracts. These are going to send information to the areas to maintain proper posture, and will receive input from the eyes, from the ear, and also the joint proprioceptors. And finally, the medial reticulospinal tracts. These will actually help control motions for more fine motor motion. Now, of course, the cerebellum also has some input into these particular motor pathways as well. So the 4 main functions for the cerebellum as far as the motor pathways go is going to monitor intentions of motion, is going to monitor the actual motion itself, is going to compare command signals and sensory information, and also finally send out corrective feedback. So a good example for this would be if you're driving your car and you're getting ready to merge into heavy traffic. So even before you take your foot off the brake and start to press the gas, your cerebellum is going to send input monitoring your intentions of motion. Should I go or should I wait? And then once you actually start to go, it actually will start to monitor the actual motion and also give you command signals with certain sensory information. So if you notice that a car is speeding up to not let you in, you know either to basically do a couple different things, either pull off the side of the road, let the car pass, gun it, really slam on the gas to try and get ahead of them, or just simply try and lean on the horn, hopefully they'll slow down for you. And finally, it sends out corrective feedback. So naturally, once that stimulus is done, let's say you're able to successfully merge, then you know to kind of slow down before you slam into the car in front of you. So again, the cerebellum is going to perform 4 very distinct activities. It's going to monitor the intentions of motion even before you actually do the motion itself. Once you're doing the motion, it will monitor, and what it'll also do is compare the command signals coming in from different parts of the cerebral cortex, and it's also working on the new sensory information, and then from that, sending out corrective feedback. So here we can see a representation of the 4 different types of activities for the cerebellum. First off, in the pons, or the pontine nuclei, as well as the motor centers in the brainstem, this is where the intentions of motion will start. It actually will initiate or monitor the actual motion from number 2, so it's receiving sensory information through there as well. It's going to compare signals from the areas in the spine, as well as areas coming in from the areas of the cerebral cortex, and it's going to send out corrective feedback as the last action there through the thalamus. As you remember, all sensory information is going to pass through the thalamus except for smell, which goes to a different pathway. Now, a few slides back, I talked about the spinothalamic pathway being dealt with a lot of healthcare practitioners out there. And we're going to talk about a theory that's very prevalent in healthcare now called the gate control theory. And this is kind of what that means. So very simply, if we look at the spinothalamic pathway, it's the 3-order neuron system we had talked about before. So if you look at this particular pathway here, we can see the first order neuron is going to synapse at the spinal cord level. It's going to synapse with interneurons, as it will synapse through the 2nd order, up to the thalamus, up to the 3rd order. So this is the entire tract, let's say, that's used for pain in particular. I don't care if it's sharp pain or burning type pain, or is it chronic pain. It's all up through the anterior spinothalamic tract. Now, fortunately for a lot of patients out there, these can be blocked. So this is where inhibitory neurons become very effective. They basically can cut down on the pain signal almost at its source. So basically, we're trying to interrupt the signal traveling up through the 2nd and 3rd order neurons by trying to affect the synapse, or actually increase interneural activity to inhibit that particular synaptic activity at the spinal cord level. So we can do this through different types of mechanical stimulation. So this can be done through acupuncture, also used through TENS, which is called transcutaneous electrical neuronal stimulation. Those of you who may have used TENS before, or may have family members that have TENS before, this is the electrical stimulation that we use, very similar to the aspect of trying to scratch an itch. So basically, by providing some kind of input, what we call mechanoreceptive input, it blocks that nociceptive input. We said nociception before is used for pain. If we can block that particular synapse or inhibit it, or hyperpolarize the nerve, for a better term. We can actually stop the pain signal from actually reaching the thalamic area as well as the cerebral cortex. Because what we wind up seeing is we see a cascade of events where if we see pain actually transmit up into the brain has certain types of pathways that'll start to cause muscle contractions. It'll start causing spasms. It'll start causing elevated heart rate. It actually starts over time. It'll start releasing enkephalins and endorphins to try and block the pain there too, but also increases swelling. So by trying to catch this pain signal of the spinal thalamic pathway, we can actually stop some of these, in some instances, destructive pathways that can lead to further problems later on. Other things that are going to be used too will include massage therapy. This is why a lot of times when we first initially do some therapies like this, it may hurt a bit, but over time it starts to relax things quite easily. Physical therapy, which I know most of you are very familiar with, chiropractic manipulation, kind of the work that I do, and a very common parallel to that is also osteopathic manipulation there at the same time. Basically, a lot of the manipulation looks exactly the same, just different applications, slightly different philosophy. But very simply, the new stimulus will override at the interneuronal level, at the spinal cord level. It'll either interrupt and or inhibit certain sensory pathways. So very simply, if we can control the sensory pathways, you can also control responses along the motor pathway that is acting upon that we just talked about. So we can stop certain types of actions from the cerebral cortex as well as cerebellum. We can catch these things relatively early. Now, one thing that it doesn't do is naturally, if some of these are coming, sensory pathways are coming in from actual damage to the area, this will take care of the pain response, but won't actually fix the damage. That's why a lot of times simply doing this kind of therapy, there has to be other corollary therapy to aid with the particular trying to fix a certain injury. So far we looked at the sensory functions as well as the motor functions of the nervous system. Now let's look at the integrative functions, especially the cerebrum. So we talked about the reticular activating system, or RAS, very important for wakefulness and also for sleep. Now if you remember in particular, the RAS will receive input from all different senses except for smell. This is one of the reasons why, unfortunately, a lot of people die in house fires because very simply smelling smoke is not enough to wake us up from a burning building. So what a lot of companies have tried doing as well, especially with smoke detectors in particular, naturally has a very annoying sound, or a siren, but also it's been known you can actually program them to actually say a person's name specifically, because we're really finely tuned to recognizing our own name to help people wake up very quickly and hopefully get themselves out of the house before it burns down. We also look at different aspects of learning and memory. This can be immediate memory, it can be short-term, long-term, basically through memory consolidation. And we'll talk about both associative and non-associative learning. So associative learning would be the stimulation between, or excuse me, the connection between two pieces of stimulation, where non-association will be repetition of the same stimulation over and over again. So just some blanket learning memory terms I want you to be aware of. We talked about association and non-association last slide. So association again is the connection between two distinct stimuli. Non-association would be the repetition of the same stimulus. Habituation would be very simply a learned response from an irrelevant stimulation, or not a strong response from a normal stimulation. So very simply, if you think of the Pavlovian dog, where they're trained very simply to salivate when ringing the bell, where they're very simply introduced to two stimulation that are not very related, like showing the mistake and also ringing the bell at the same time. They learn through habit to very simply salivate to the ringing bell. Another type of learning that we see is sensitization, which I see a lot in my practice. You see it in a lot of doctors' offices too. It's an increased response to the same type of stimulation, most of the time, pain. So for example, if someone sprains their ankle, they may sprain their ankle less severely, let's say a second or third time down the road, but the pain response is still the same. The patient is very sensitive to that type of pain. Other types would very simply be bee stings, spider bites. Other types of pain responses where a lot of times the initial pain response can be very dramatic because of the increased response, but then the next couple instances where the stimulation may not be as strong, you still get the same strong sense of pain. And last we'll talk about are going to be declarative and non-declarative. Main difference is declarative will be mostly learning about facts, names, or faces. Non-declarative mostly for motor skills and procedures, simple things like riding a bike, learning how to walk, that kind of thing. Okay, next let's look at two different aspects of sleep. So basically we have non-rapid eye movement sleep and also rapid eye movement sleep. First we'll talk about non-rapid eye movement sleep, where we're going to encounter four different stages. Stage one, very simply, you have the eyes closed, you have fleeting thought, not very tough to wake someone up. Also when you first awaken, you have the general feeling that you're going to sleep. Stage two is a little bit deeper. You start getting dream fragments, but again, still relatively easy to wake. So in other words, you wake up and you're still somewhat refreshed. Stage three, it's usually a moderate or deeper sleep. Your temperature and blood pressure start to decrease. A little tougher to wake someone up at the stage three sleep. Stage four is the deepest sleep. It's stage three, but also you have muscle tone will start to decrease at the same time. Now we fluctuate through each of these four stages as we sleep. So what happens is, very simply, you go from stage 1 to 2 to 3 to 4, and it ramps back up going the opposite way. So it goes 4, 3, 2, 1, and then basically goes a very wave-like pattern from stage 1 to 4, and then back again. Now, as far as REM sleep goes, most of your dreams are going to occur at this particular stage. There's no bearing, though, on whether you actually remember them or not. Most dreams do occur at this stage. Very rarely will they be found in the non-REM sleep. But what we do find is your brain blood flow and oxygen consumption is very high, sometimes higher than what you normally would have when you're fully awake. In this instance, though, very different from non-REM sleep, the motor neurons are going to be inhibited. Very simply, if you have a very active type of dream, very simply you'll get little flickers of movement with the hands, with the feet, and also with the eyes. But essentially, it inhibits the motor neurons, so it essentially basically paralyzes the skeletal muscle except for breathing and for your eye motion. Some people have seen this, especially with kids. If you look at babies while they sleep, a lot of times you'll see the finger twitching or the toes twitching. You see this in animals in particular too, especially with dogs and cats. This is kind of what happens during the REM sleep. Very simply, your prefrontal cortex is inhibited. If you remember, this is your reasoning center. This is where your personality is. But your limbic and the visual association areas are very excited. So a lot of times we find, especially in dreams, you do things, or at least you perceive things that you don't normally associate with yourself when you're fully awake. This is the reason why we see that is the prefrontal cortex is being blocked, so to speak, and the more primal type of urges are seen therein. The other thing that I want to point out to you as well is sometimes you'll see, or actually very rarely we see any kind of words in your dreams as well, actually text. It's very, very rare to see in most people's dreams, again, because the prefrontal cortex is going to be used for the declarative centers there as well, also inhibited. And finally, like I mentioned before, the stages will ramp up and down in order and back in reverse during various periods of sleep. And these do change from night to night as we sleep, and also change from person to person. So let's talk about some disease patterns. One in particular is Lou Gehrig's disease, also known as ALS, or also known as amyotrophic lateral sclerosis. So this very simply, it'll attack the motor areas of the cerebral cortex, attacks both the upper and lower motor neurons. It affects the lateral white columns in particular, so the cortical spinal and the rubrispinal. So if you remember, in particular, the cortical spinal is going to work both the proximal and distal portions of the limbs. The rubrispinal is going to run through the red nucleus. This will actually draw input or take input to the cortical spinal tract, allow more for fine motor control. But of course, we start to lose that because this particular disease starts to break down the lateral white columns in particular. So it eventually will cause muscle weakness and atrophy, and unfortunately will result in death, basically losing the control of breathing. Syphilis, that is going to be caused by the bacterium Treponema pallidum. This can also cause degeneration of the posterior columns of the spinal cord. You start to notice loss of gait control. You occasionally get what's called a spastic or a spasmodic gait. So it's very uncontrolled, almost like what we call a steppage or a slapping gait, where you really hit the ground hard with your feet. So it's a very awkward type of motion. Fortunately, syphilis can be cured if found early enough. Very simply, some of these areas you can restore some of the function, sometimes not all, but you can restore enough of the function to live somewhat of a normal life. Next, we have Tourette's. Tourette's is always fun to deal with. I've had patients with Tourette's in the past. It can be any variation of different types of issues. You can have different types of motor tics, involuntary motions. There could be something along the face. It could be along the head. It could be a certain motion to the arms sometimes there too. Occasionally get vocal tics, or a lot of times you'll get involuntary vocal sounds, like one patient who barked another patient who naturally use different types of slang or different types of vulgar language. With different kind of medications, you can kind of staff this off a little bit. Don't know which medications are really used, but there are some things that will basically block, usually like as a GABA type of medicine, they'll help inhibit other neurons. But eventually, though, if left unchecked, this can cause disruption of a lot of cognitive neural circuits. So in other words, their capacity to learn certain things can be inhibited due to Tourette's. Now, as far as basal nuclei disorders, we'll just touch upon these very briefly. This can be more easily defined through a cognitive physiology course or even a psychology course. But as you remember before, the basal nuclei are responsible for the starting and stopping emotions. We see issues with the basal nuclei with people with OCD, or obsessive compulsive disorder, where they lose the ability to either stop and or start certain types of functions. So you usually see problems with the neural circuits that actually will attach to the limbic system as well. Other types of basal nuclei disorders include schizophrenia, where in this case the substantia nigra just secretes an excessive amount of dopamine. So this can lead to hallucinations, paranoia, distortion of reality. There's a bunch of other things that are leading to this as well, but again, just knowing that both schizophrenia and also OCD, this is usually due to a problem with the basal nuclei themselves. If you look for more information, again, there's courses out there that go very far in depth with these types of issues. Now let's talk about aphasia. Aphasia is going to be the inability to speak appropriately. We see two types. These are going to tie into two different parts of the brain we had talked about way back on the brain anatomy chapter. We look at expressive aphasia, which is usually an issue with the Broca's area. This is where the person knows what they want to say, but they can't actually form the actual words themselves. They can bypass this by either writing or typing or texting what they want to say, but again, once they bypass the actual vocal portion, they can actually have a decent conversation with someone else. Some have even been taught to sing, since Broca's area is not really used for singing responses, only for the spoken word. So some people have been trained, some occupational therapists or speech pathologists have trained some of their patients to use singing as a way of answering a person's question. Now, this is different from receptive aphasia. This happens with damage to Wernicke's area, where very simply we call word salad. So it's a faulty understanding of the written or spoken word. So again, they can think what the response is, but unfortunately they cannot express what they want to say. So they come out with a very strange type of sentence. The one I was used before is if we say very simply put the book on the shelf, comes out instead is put the horse back on the grill. It doesn't come out exactly what they want it. They can't form the words, or they can't think of the words to form the actual sentence. So again, expressive aphasia is more or less not be able to vocalize the actual word, but the person can consciously think of a response, and they can write it, sing it, text it. Whereas receptive aphasia is going to be damage to Wernicke's area, where expressive is more from Broca's area. Receptive aphasia is more or less where damage, where they cannot form an appropriate sentence as far as the answer goes. All right, so this finishes up the chapter for the sensory motor integrative systems. Again, some of the things from the last lab, you can find the answers to the questions in this particular lecture. And that's pretty much it. We got one more to go. Special senses. It is a long one. I may break it apart into two sections, and then it's just a race to the final.